Hi, everyone. Thank you for joining us for the Robert Wood Johnson Foundation's Systems for Action Research and Progress webinar. We're glad you're here and we have some really exciting research and progress to share with you. My name is Carrington Lott and I'm the Program Manager for Systems for Action. And if you're new to us here at Systems for Action and less familiar with what we do, we're a signature research program of the Robert Wood Johnson Foundation. We study ways to align and connect medical, social, and public health systems with the goal of improving population health and advancing health equity. We support studies around the country testing a variety of ways to connect, align, and integrate medical, social, and public health systems. All of our studies cover a range of topics and alignment methods. If you want to learn more, you can check out systemsforaction.org to learn more about our 20+ studies that we're supporting. Research and Progress webinars serve as an opportunity for our grantees to do innovative work that is important to us. We feature studies at every stage from early phase, when projects are just beginning, to the later in the process when they have findings. Today we'll hear from a project led by a team at UCLA, the Department of Public Health, that is looking to answer the question, closing gaps in health and social services for low-income pregnant women. This project is still in fairly early stages, and we look forward to hearing more about the background on the project, research design, and work they have planned. If you have questions, please enter the Q&A box, and we will have time for questions at the end. Today we'll be hearing from Irene Vidianti, Will Nicholas, and Aaron Salibi. To give you a little bit about their background, Irene received her PhD in Industrial and Systems Engineering from the University of Southern California, and her bachelor's and master's degrees in Information and Computer Engineering from Cambridge University. Dr. Vidianti is a data scientist for the Los Angeles County Chief Information Office. She has expertise in using data science and systems science to evaluate the impact of interventions on multiple sectors and with using data-driven decision-making at both operational and strategic levels. Dr. Vidianti is the principal investigator for the study. She is currently also the co-lead for a project to assess countywide performance and studying and supporting strong children, families, and communities in LA County. We have Will Nicholas, who is a resident of Los Angeles. He received a BA in Spanish Literature from the University of California, Berkeley. He received an MA in Latin American Studies and an MPH in Population and Family Health from UCLA. He also received his PhD in Health Policy from Yale University. Dr. Nicholas joined the LA County Department of Public Health, where he directs the Center for Health Impact Evaluation Center, and he joined this in October of 2015. In this role, Dr. Nicholas authored 4 health impact assessments, 1 on local affordable housing ballot measures, 1 on local homeless services ballot measure, and 1 on the City of LA's Mobility Plan 2035. And 1 on cannabis regulation. Before joining the LA Department of Public Health, Dr. Nicholas spent 5 years at the UCLA Center for Healthier Children, Families, and Communities, where he co-directed the Los Angeles Ventura Study Center of the National Children's Study. And then we also have Dr. Erin Salibi, who received her master's in Public Health and Healthcare Leadership and Prevention, and her medical degree from the University of North Carolina, Chapel Hill. She completed her residency training at UCSF, followed by a Robert Wood Johnson Clinical Scholars Fellowship at UCLA. Dr. Salibi is board certified by the American Board of Obstetrics and Gynecology and serves as Director of Women's Health Programs and Innovation. She has been Principal Investigator in LA County for the Centers for Medicare and Medicaid Innovation Center's Strong Start Initiative, MAMA's neighborhood, which stands for Maternity Assessment, Management, Access, and Service Synergy throughout the neighborhood for health, an Office of Population Affairs grant for HIV testing expansion and bidirectional linkage to care, and now a HRSA Healthy Start Program grant. So with that, we thank you all for being here to share your work with us, and I'll turn it over to our presenters.
Thank you, Carrington. And thank you everyone for joining us this morning or afternoon, depending on where you are. So I'll start with a study overview. So the study that we just started in the middle of this year, and the study time frame is 2 years. So this will end in the middle of 2021. And broadly speaking, the aims of the study are to evaluate the long and short-term outcomes of the Mamas Initiative, of which Erin will talk more about, and also to assess how the organizational and implementation issues of the program affect the outcomes. I'd like to point out that we have a strong research team with collaborators across multiple departments in multiple sectors, including LA County Chief Information Office, which I'm from, the Department of Public Health, which my co-PI Will is from, the Department of Health Services, which our co-investigator Erin is from, and where Mamas Initiative resides, and where Erin is the head of that initiative. And we are also collaborating with a few other agencies and departments, including WIC, USA Children's Data Network, and a few other LA County departments. So I'm trying to advance the screen. Oh, okay, there you go. So I'd like to, technical difficulties aside, I'd like to acknowledge that the contributions of the large study team that we have that spans these three departments, the CIO, DPH, and DHS. You will hear from three of us today, but I'm really happy that we have a strong research team here. And we actually have a few of the members of the study team here with me in this room. So I'd like to start with why we think that Mamas Initiative is necessary and why we're doing this study. First of all, the Department of Health Services, or DHS for short in LA County, is a network of safety net hospitals that serves low-income pregnant women. 95% of the births among the in DHS are covered by Medicaid. And unfortunately, we have poor birth outcomes among this population. As you can see on the chart on the upper left-hand corner, the rates of preterm birth and low birth weight in DHS in the county are twice as high as rates for all births in the county, and these are from 2013. And we think that that's partly because of the role of social stressors in influencing this poor birth outcomes and also poor health outcomes later in life. So as you can see from the graph on the lower left-hand corner, the rates of social stressors in the DHS prenatal population are high. 19% for substance abuse, 30% for domestic violence, 16% for housing stability. This points to the need to address the social determinants of health so that we can improve birth outcomes and reduce inequities in the birth outcomes. But this means that we need to address it using a multi-pronged approach that involves many sectors and partners and across the life course. And in particular, the critical period of intervention is during pregnancy and during the first year of a child's life. The challenge here is that the comprehensive services and supports that are needed in this multi-pronged approach are often siloed within distinct agencies and across the different sectors. And this leads to service fragmentation, poor alignment with what the moms actually need, and inequities in access. So with that, I'd like to hand it to Erin Salibi so that she can talk about how Mamas Initiative is addressing these challenges and how the initiative is sorely needed in LA County. Erin, the floor is yours.
Hi, everyone. Sorry about the technical difficulties. So for those of you who don't live in LA or know much about LA, it's a very big place. There's 11 million residents and about 150,000 births countywide. The LA County Department of Health Services has 3 maternity hospitals spread out throughout Los Angeles County, but the volume of deliveries isn't what it was back in the 1980s when LA County really served the bulk of the safety net population. What we have now is sort of a smaller but more significantly stressed group of women with a lot of additional medical comorbidities related to their social stress and oftentimes access issues to care. These stressors are, as Irene mentioned, borne out in terms of their birth outcomes in preterm birth and low birth weight births. As you can see here, California, is sort of tracking along close to the national average. Los Angeles County, not too much worse in terms of these birth outcomes, but within DHS, you start to see some staggering disparities, followed by SPA 6 and 8, which is those southernmost, sort of South Central and South LA maternity hospitals that DHS runs, exhibiting the poorest rates of birth outcomes, even worse than that of the worst country globally, which is Malawi. And again, this is based on some data that's historic that we went to when we were first looking into the formation and creation of Mama's Neighborhood. So as was alluded to, Mama's Neighborhood was a response to seeing these staggering statistics in our hospitals. It stands for Maternity Assessment, Management, Access, and Service Synergy in the Neighborhood for Health, and has been recently expanded through Mama's Visits as a part of our 1115 Medicaid waiver. The conceptual framework that we were sort of working with as we developed the intervention is that there are a lot of different social stressors that contribute to something called allostatic load, which for those of you who work in the space, certainly this is a concept that's been championed over several decades now as kind of the combined weight of stress that exhibits itself through biochemical pathways and triggers that precipitate preterm and low birth weight births. But as you can see, most of the things that contribute to allostatic load aren't those things that we're usually addressing in the context of standard prenatal care, or even within the standard context of medical care in general within the health system. And so that really forced us to think about, okay, from a driver's perspective, and this is again through the Strong Start Initiative, original funding through CMS, was if we were going to decrease preterm and low birth weight births, we thought that we would primarily drive that by decreasing stress, substance abuse, mental health, and some of the known medical comorbidities that are associated with these poor birth outcomes. But sort of impacting stress and impacting mental health and even substance abuse typically hasn't been an integrated component of medical care in the prenatal context in many settings. And so we had to sort of think about upstream drivers and how we were going to better organize and deliver care to activate these other parts of the social network and the social safety net for women and families to address these primary drivers of outcomes. And so our core assumptions, just in summary, were that poor birth outcomes were a result of multiple factors, including these medical, social, and environmental determinants, which we would sort of globally put into a sort of a stress index, if you will, of allostatic load. That we weren't screening and identifying high-risk mothers in these spaces, especially in the social environmental spaces and mental and behavioral health as systematically as we would like to. And that we weren't aligning our service provision with those specific sort of stressors in mind. And so it was sort of prenatal care with everybody gets everything, whatever that is, the shortcomings and the potential enhancements that were available here locally, but that it hadn't really taken into account that some women just have a lot more stress than others. And that the care, when we did deliver it, was fragmented and lacked coordination and led to a lot of sort of holes and gaps that would potentially precipitate some of these poor outcomes. And so what we hope to design in Mamas was a comprehensive coordinated approach that was really addressing these three core pillars, physical, mental, and social health, as a part of the formal care plan. So in order to do that, we really stepped back and looked at how we could sort of disrupt and redesign the system and really change the care package that women and families were eligible for at entry to prenatal care, and tried to really put them, women and families in the driver's seat of that care. that we needed to do an enhanced engagement and assessment process and really connect with our neighborhood agencies to address responsibly some of those, especially social determinants of health that were inconsistently addressed in standard prenatal care. We also added some enhanced content within the health system, including groups and classes, both groups that might relate to mental health, such as cognitive behavioral therapy, as well as a mixed prenatal care and resiliency, or sort of a CBT light, delivered by paraprofessionals in the community setting. We also added mobile and community visits. We don't call them always home visits, as we have a high proportion of folks in our homeless population. So, and then I think just in terms of telegraphing this really very physically to our patients, where it was possible, we did what we could to redesign the physical footprint of our services, such that we put our social needs and the folks that did the work to connect folks in the neighborhood up front, literally up front in the clinic. So right after registration, those were the next folks available to you, instead of it being somebody who's in the sort of back corner, cubby, closet of a clinic, but that really the importance of these social needs were really, visibly present to all folks when they walked in the door. In terms of who was going to then deliver some of these enhanced components of our care package, we shifted from what was a very top-down hierarchical model of people seeing high-risk OB doctors, which if you're in the field, again, maternal fetal medicine isn't cheap, but to really sort of organizing the bulk of the patient's time around interactions with various care team members, including community health workers that we call care coordinators, being the point person for access, content, and care navigation, nursing staff and social workers who function as therapists rather than as resource and referral sort of primary work. They are providing actual mental health therapy and care through CBT or IPT type of programs. Our nursing staff, both in the clinic as well as in the field, doing enhanced care management, especially for women with comorbid medical conditions. And then, of course, our providers, our nurse practitioners, PAs, midwives, obstetricians, and maternal fetal medicine specialists, in addition to family medicine, where those folks are in the mix, all engaging in a collaborative care team approach that also brings the whole clinic staff, sort of soup to nuts, the registration clerks, the dietitians, the health educators, all of the folks who participate in care at the clinic, participate in collaborative care team meetings to really engage a multidisciplinary approach and see women and families and their lives from a variety of lenses and angles to best meet their needs and form their care plans. We have organized into unit-based teams to find operational solutions to creating workflows that make sense and create an improved patient experience. And then again, leveraging the neighborhood network and acknowledging that the physician and indeed even the unit-based team or the healthcare system collaborative care team is only one part. And folks have often referred to this as the 5,000-hour challenge, which is acknowledging that there's 5,000 hours in a year that patients don't spend with us in the healthcare system, and that in those hours, the neighborhood network is really what we need to leverage to address, especially their social and behavioral health needs. Oops, sorry. In terms of our systematic organization and population health management to both assess and address these needs, we developed a comprehensive tool that's utilizing, where possible, measures that have been validated in populations, multilingual, multi-ethnic, and pregnant populations to best characterize some of these social and behavioral health needs. And this is then combined into a global stress score, which helps us, again, decide who is in the sort of most stressed group in our population and who would sort of have a more moderate assessment of stress at any one point in time, and then who sort of has fewer stressors, but any individual need would still be taken care of. And our service intensity is again aligned with this assessment and this combined global stress score So folks who are the most stressed will have care contact by a care manager or care coordinator at least weekly, and maybe even daily at the beginning of addressing some of these needs. The most moderate risk group monthly, and then the folks who have the most social stability would be in touch at least trimesterly, but often would be in contact more regularly as needs would arise with their care coordinator or their nurse care manager. Taking these assessed risks and then operationalizing their connection to the neighborhood network for health was done by a prescription for health and an individualized care plan that is very explicit about the inclusion of these agencies and other referral resources as a part of their prenatal care. So that telegraphing and messaging again to women and families that we see these issues and these stressors as really important for your overall health, well-being, and birth outcomes. It comes in the form of a prescription that links women specifically to geocoded entities that are close by their site of prenatal care, and usually that's close by their home, to better activate their neighborhood network of care. And these folks all exist in partnerships at various levels of information sharing with our health system as negotiated by neighborhood network partnership contracts. Not paid, but just, again, information sharing about clients. The neighborhood network is broad, includes a lot of different domains that specifically, hope to address and work with women in these various areas of stress in their lives. And this is where we get into the analysis of how well this is working.
Thank you, Erin. I think Erin has painted a very good picture of why the Mamas Initiative is sorely needed and how the program is really trying to get at the needs of the moms in LA County that are served by DHS. So we think that it's very important to study this, the impact of this initiative, and hopefully the impact of the study, hopefully the study results can also be used to inform other ongoing efforts in the county that try to address pregnancy, birth, childhood outcomes, and health inequities. So with that, we started with a logic model for the study. So on the left-hand side of the logic model, we see how the program components of Mama's Neighborhood in the different sectors, healthcare, public health, and social services are called out here, how Mamas align this program components using several system alignment mechanisms, and how all these different mechanisms activate the key drivers of culture of health action framework by fostering cross-sector collaboration and strengthening integration. And all of those hopefully will lead to improved population health, well-being, and equity. So on the right-hand side of the logic model, we have a list of outcomes from proximal to distal across different dimensions, from maternal and birth and childhood outcomes to adult outcomes. And in our research questions, we're going to look into several of these outcomes. So these are our 3 areas of research questions. The first one is our overarching goal of the study. So this is our main research question. So what are the short and long-term outcomes of the Mamas Initiative? So we're trying to look at both the more the proximal as well as the more distal outcomes of the initiative. So we want to look at maternal and birth outcomes among Mamas clients compared to outcomes among moms who did not participate in the program. So this is the more proximal outcome. And we also want to look at the more distal cross-sector outcomes among Mamas clients compared to outcomes among moms who did not participate in the program. And for this part of the research question where we're looking at the outcomes, we're going to use quantitative and qualitative analysis. And then the second area that we're looking at is the impact of the program on health equity. So specifically, there are 2 components to this. The first one is on whether the needs of the high-risk group have been adequately met by the program. And the second one is on whether the program has reduced inequities in maternal and birth outcomes. And again, we're going to use quantitative and qualitative analysis to answer these research questions. And finally, we also want to understand how organizational and implementation issues affect outcomes. So this goes towards that partnership with the neighborhood agencies that Erin mentioned that is an important component of the program. We want to understand how effectively MAMAS has aligned linkages across the social healthcare and public health sectors. And for this last part, we're going to use qualitative analysis and network analysis. We're using quite a number of data sources, both secondary and primary, for this study. So for the secondary data sources, we're using the MAMAS program data. We're also going to use vital records data, specifically the birth records and the birth cohort data for LA County. And we're using two linked longitudinal data sets. The first one is the Information Hub, which is hosted here at the CIO, that links data across several county departments across multiple sectors, including social services, housing, health, mental health, justice, and workforce. And we're also going to use USC Children's Data Network, which is also another linked longitudinal data, mostly children's data. And we are also going to collect some primary data in the study. So we are going to collect data through key informant interviews and focus groups, as well as the network survey. In terms of research methodology, I think you've seen that we're using network analysis, qualitative and quantitative analysis. We're using a concurrent embedded mixed methods approach here. So we're using quantitative methods, there's a typo here, quantitative methods including statistical analysis to evaluate how the impact of MAMAS. And we're also going to use network analysis to capture the partnership dynamics in the MAMAS neighborhood program. And we also want to add contextual depth to our quantitative findings using qualitative methods because we really want to understand the potential mechanisms that underlie the findings from our quantitative analysis. We will consider the quantitative and qualitative data together to get a comprehensive and holistic understanding of the participants' experiences with MAMAS, whether the program has been delivered as intended, capture a full range of program outcomes, and we also want to understand how the implementation and delivery was limited or enhanced, or has limited or enhanced the program effectiveness. And what we'd like to do is to really consider the quantitative and qualitative data together to come up with recommendations that are actionable for our stakeholders. So I'm going to talk about the different components of our research. So I'll start with the network analysis. So this component of the study, the network analysis component, goes towards answering this research question on how effectively MAMAS has aligned linkages across the social healthcare and public health sectors. So this goes towards understanding how well that partnership network that MAMAS has with the neighborhood agencies have been working. So for that, we will use MAMAS administrative data as well as network survey data that we will collect in this study to generate this partnership network visualization to generate a graphical representation of the partnership network with how the agencies are linked to each other based on referrals and other partnerships. And we will then use that to assess the network scores to assess how effectively MAMAS have aligned linkages across the different sectors within its network. So we have on the screen here a simplified hypothetical example of what the MAMAS partnership network may look like. So we are going to produce something like this with the data that we have from MAMAS and the network survey to assess the effectiveness of linkages. The quantitative analysis portion of the study forms the bulk of the study. And there are two components to that. But first, I will talk about the data linkages. As I mentioned before, we have 4 data sources, 2 of which are already linked longitudinal data by themselves. We will link these 4 data sources. Some we will establish the links explicitly, some already are established, and some of the links are implicit based on the chaining of links, the chaining of explicit links that we are going to establish. So we're going to link this 4 data sets And once they have been linked, we will de-identify the data sets for the purposes of analysis. And I'd like to also point out that since we have extensive cross-sector data in our linked data sets, we should be able to study a number of interesting things, including how the program utilization varies across the multiple systems. We also will be able to see how events in one system affect what happens in other systems later on in terms of service use and outcomes. And we would also be able to see how the patterns of cross-system effects vary over time. So the first part of our quantitative analysis goes towards answering the research questions on the more proximal outcomes. So, this is, I think I lost one slide here. We have two portions of the quantitative analysis. So the first one is on the maternal and birth outcomes. So that's the more proximal outcomes that I mentioned. So ignore the text on the screen because it seems like we have lost one slide. But for the first part of the quantitative analysis, the outcomes that we're going to look at are low birth weight, infant mortality rate, preterm birth, and maternal mortality. And for this outcomes, we're going to use a subset of our 4 data sets. We're going to use the MAMA's data linked with the vital records data. For the comparison group, we're going to use a select sample of non-participants resembling MAMA's clients, and we're going to construct that comparison group using propensity score Corson's exact matching. And for the analysis method, we're going to use multiple regression. We're going to control for several variables such as prior adverse birth events, smoking history, and so on. And we will also conduct subgroup analysis to understand whether the program reduces inequities in maternal and birth outcomes among the different subgroups, for instance, across race, ethnicity categories, or across different risk levels. And then the second portion of our quantitative analysis, now we can actually look at the text that we have here on the screen. We are going to study the more distal outcomes, the longer-term cross-sector outcomes among MAMA's clients compared to the outcomes among moms who did not participate in the program, as well as the needs of the high-risk group specifically. So for the second portion of the quantitative analysis, we're going to look at several outcomes, including housing, healthcare and mental health utilization, food assistance, specifically CalFresh, income assistance, specifically CalWorks, child welfare and justice involvement. So for the data use, we're going to use all 4 of the data sets that we have. So MAMA's Information Hub, which includes county departments data, vital records, as well as Children's Data Network. For the comparison group, we're going to use the same comparison group that we constructed for the prior part of the quantitative analysis that we will construct again with propensity score, course, and exact matching. We're going to use difference in differences analysis for the analysis method. And we will also do subgroup analysis here to assess whether the high-risk group have improved cross-sector outcomes due to linkages to services. And as I mentioned, we're using a mixed methods approach. So we really want to have the qualitative analysis portion also really complements the quantitative and network analysis portion of our study. And at this point, I will hand this over to Will, who will talk about the qualitative analysis portion of the study.
All right, thank you very much, Irene. Appreciate that. The qualitative portion of this study is will be supporting all 3 of the research questions that Irene went over, but particularly focusing on that last question about how organizational implementation issues and actually even systems issues affect processes and outcomes of care. Just some of the nuts and bolts and overview. Our analysis and data collection will be conducted by contracted researchers, but we've required that they be based in Los Angeles County. So they'll be working very closely in consultation with our research team and with the MAMA's program staff. Essentially, they'll be conducting focus groups with MAMA's providers and with MAMA's patients, 3 to 4 groups with each of those. We'll be doing those groups in English and Spanish. And then we'll also be doing key informant interviews with 8 to 10 senior staff of both the MAMA's program and key partner agencies that I'll be talking about in a bit. So to focus on the focus groups, waiting for that. All right. Well, wait. All right. So a little more information on the focus group. So providers will be recruited in consultation with the Mama's program staff. We want to include both medical and non-medical staff. As Dr. Sleepy mentioned, the care coordinators and the team-based approach they have is really critical. So we may actually do separate focus groups, one with the medical providers and one with the non-medical staff. The patients will be recruited at Mama's clinic sites with the help of Mama's program staff. We're looking to try to get a mix of parity and risk levels to add some richness to the conversation and to potentially be able to draw some comparisons. The protocols for the focus group will be developed in consultation with the research staff and Mama's program staff. Likely topics for those will be looking at across multiple domains, what factors contribute to successful adherence to this cross-sector care plan that you saw Dr. Salibi present a little bit ago. We'll be looking both at the individual, interpersonal and family level, at the provider level and the network level, looking to see what influences and what contributes to the success, not only to the care plans, the process of care, but also to patient outcomes and the cross-sector outcomes for patients. We also want to look at specifically ways Mama handles high-risk patients and situations. And we also want to look at perceptions of some distinguishing characteristics of the Mama's program versus other perinatal programs. Our key informant interviews, we will be recruiting those interviewees from leadership of agencies involved in our LA County efforts to reduce inequities in birth outcomes. I'll talk to you a little bit about that later. So we will likely include county department leadership, members of community-based organizations, and First 5 LA, which is a local funding agency focused on the first 5 years of life. The protocols, again, will be developed in consultation with our team and the Mama's program staff. And some of the topics that will include these interviews are designed to really take a step up and look at systems level factors that contribute to both the successful adherence to the Mama's care plans and to positive patient outcomes. So again, we're looking to see what's happening at a broader systems level across the county in terms of some of the efforts that are going on more broadly to reduce inequities in birth outcomes. And finally, so this is a mixed method study. We're going to be incorporating the qualitative data into study analyses and findings. So we'll be the qualitative team will be incorporated into our daily operations. We'll be learning about key themes from these focus groups and key interviews, and they'll be used to inform kind of proactively the quantitative analysis strategies and model specifications, and then also on the back end helping us to interpret some of the findings of the quantitative analyses. Also, we'd like for the qualitative findings to actually stand alone to inform Mama's program and systems improvements. Other jurisdictions seeking to reduce inequities in birth outcomes through cross-sector approaches like Mama's, and also this broader LA County initiative that I'll be speaking about shortly. Thank you.
Thank you, Will. So this portion, I'm just going to go over very briefly. I just want to mention that since we have a lot of moving parts in our study, and this is a fairly complex study, we think that it's important to have a list of milestones so we know where we are and where we may need to catch up. And this is our list of milestones showing where we are, and the texts that are in blue here show where we've made significant progress on, and we should be able to achieve those milestones shortly. And again, because this is a fairly complex study with lots of moving parts, we also think it's important to have a study plan to know where we are and where we need to go. And this is just a brief overview of our study plan for the first year and for the second year. So I'd like to close with talking about the capacity for the study to potentially support system alignment and system change. And we'll talk further about this, but we think that the study has the potential to inform system change investments in LA County because of its alignment with many countywide and departmental priorities. So the study can potentially inform multiple ongoing efforts that improve pregnancy, birth, and childhood outcomes, as well as health equity. So one instance in which this study is aligned with countywide and departmental priorities is in the action plan for the health agency's Center for Health Equity 5-year action plan that identifies the priority areas to reduce health inequities, including the gap in infant mortality rates between white and African American babies. And this is one of several county priorities that the study is aligned with. And in the commentary portion later, Will is going to talk about the African American Infant Mortality Initiative, which is an initiative that was launched in line with this action plan, this Center for Health Equity Action Plan, and he's going to talk about how that is aligning with our study. We also recognize that to inform system change investments, we really also need to engage key stakeholders who will be responsible for making relevant decisions. So for this study, we will also convene a steering committee that is composed of decision makers from various county departments and other stakeholders, so we can get guidance from them on the potential dissemination channels where people who can make the system change investments are more likely to respond to. And we would also like to get their input on how to present the study results in a way that inform policy and practice. And with that, I'll hand this over back to Will to talk about that African American Infant Mortality Initiative, which is an initiative that is a Department of Public Health initiative, and how that aligns with our study.
Thank you, Irene. So my voice might sound familiar to you, but don't be fooled. I'm wearing a totally different hat right now, and I'm actually representing Dr. Debbie Allen, who could not be with us today. She is the head of our division in our department, overseeing one key component of a broader focus on health equity that our department launched a year ago. And this is a focus on reducing the gap in Black-white infant mortality in LA County. What you see here on the screen, I guess, let's see, that up there, is basically this is the planning document that was released last year. We're now 1 year into a 5-year plan on reducing Black-white infant mortality. It's called AAIM, African American Infant Mortality Initiative. That's what we refer to it as. Next slide. This is data that is often used to present the overview of this initiative. You've seen data on infant mortality, on preterm births and low birth weight. This just shows the incredible 3-fold gap in infant mortality between African American and white infants. Even though the rates are going down, this gap is actually increasing, the Black-white gap. And this next couple of slides just kind of hammer home the notion that it's really not, if you look at typical indicators of socioeconomic status, like here we're looking at education, these really aren't driving those differences, because at every single education level, that disparity exists between African Americans and whites. The next slide also shows you that health behavior is important to screen for risky behaviors, but even white mothers who smoke, white pregnant women who smoke, actually still do better than African American women who don't smoke. So really, health behaviors isn't really the primary driver here. Next slide. What we're really looking at with our initiative, which is very much aligned with Mama's, is that it's really about reducing chronic stress in women's lives. This is one of the 3 primary goals of the AAIM initiative. This really echoes and is really in parallel to the slide that Dr. Salibi showed about allostatic load. And so just as the Mama's Project is working to address allostatic load through a comprehensive perinatal care program, the county is also looking at this kind of county-wide. So addressing this by addressing racism through implicit bias training for our 100,000 LA County employees, addressing these issues of poverty by prioritizing high-risk pregnant women in affordable housing placements, also maximizing the use of the earned income tax credit among high-risk pregnant women. We're addressing exposure to violence. The Department of Public Health just this new county Office of Violence Prevention is now housed within our Department of Public Health and has focused programmatic work around reducing exposure to violence in the perinatal period. And also we're going to be doing a lot of public awareness, raising awareness about these issues through social media and communications. The second goal of the initiative gets kind of closer to where Mamas is, looking at blocking the pathways from social stress to physiological stress. Taking on social isolation by promoting group models of prenatal care, much like the Mamas program is doing with its kind of mother-focused, family-focused approach. Building social support through expanded home visitation programs. Mamas has a home visitation component. Training providers across the county to recognize stress and address it through social support and self-care. Building self-confidence of parenting women through breastfeeding support, home visiting and mothers groups. It's also a community building component. And then the third goal is really at the patient care level, intervening as soon as possible when stress has taken a toll on health. One is through something called One Key Question. I should have included the copyright symbol there. That's this question that we're now going to be asking across all of our primary care clinics, which is, what would you like to become pregnant in the next year? Really trying to get in early on as women are thinking about becoming pregnant. Risk reduction, key piece. Universal access to effective medical interventions to avert preterm births. Again, Mamas very much focuses on this. Enhanced mental health services, and then referral to services for women whose babies are born preterm or with developmental or congenital health problems. Our partners, and this is these partners overlap directly with our partners on the Mamas Initiative. In fact, some of the people on our steering committee that I already mentioned are also our partners on AAIM, and they include women affected by birth outcome inequalities. We'll actually be collecting data from Mamas through our focus groups from women directly. Will be these other county agency heads, which we'll actually be speaking to through our Informant interviews on the Mamas Project, community-based organizations and providers, birth hospitals, philanthropy and healthcare payers. In fact, Medi-Cal, which is our Medicare program here in California, is the primary payer for Mamas, and so we're hoping to feed back information to the Medi-Cal program statewide. And then our California Department of Public Health, which is actually the holder of the vital records data that we're using for this study, and where the IRB is located, where we've gone through our human subjects protection process. So many overlaps between our partners on this AIM initiative and our work with the Mamas evaluation, and Mamas evaluation definitely being used to inform the broader AIM initiative. Thank you.
So Carrington, I guess we're handing this over to you.
Great, thank you. I appreciate you sharing all the exciting things you have coming up with your research. We have reached the question and answer section of this webinar. And I see that we do have some questions that have come through. If you do have any that have come up, please enter them in the Q&A box at the bottom left-hand side of your screen. So we will start with our first question here from Ali JP. Please speak more about implicit links during the linkage slide. Also, could you speak about how you navigated permissions to link the birth data?
Sure. I can answer that question. So in terms of the implicit links that was mentioned in the slides, so these are really because of the limitations in terms of how you can use the vital records data. So what we're going to do is we're sort of going to chain some of the links to be able to link two data sources together. So in terms of the linkages that we're going to do, we are going to link the mama's data to Information Hub data. And we are also going to link the vital records data with the Information Hub data so that we can, so the implicit link that I mentioned is that we end up having a link between the vital records data and the mama's data, because now we have sort of an intermediary linking the two of them together, which is the Information Hub data. So that's what I meant by implicit link. So we're not going to make, we're not going to link the two data sets explicitly, but we're going to have sort of like an intermediary data set, or we're going to link the two data sets too. That's how we're going to end up with some of the linkages between our four data sources. And I think there was another, sorry, what was the second component of the question?
The second component was, could you speak about how you navigated the permissions to link the birth data?
So in terms of the permission to link the birth data, so we do require the state IRB's approval for that. And we have received approval for one part of the linkage, and we are going to request approval for the other linkage that we are going to do with this data. Yeah, that's possible. You do have to go through the state IRB to get approval for these linkages.
Great, thank you for clarifying. The next question that has come through is, what type of healthcare services coordination is done? Is oral health also included?
Erin, if you're still on the call, I'll let you answer that.
Yeah, sorry. So we don't have a huge focus on oral health care, although, you know, we certainly do refer, and we have local, you know, on-site services within DHS for oral health. So it's not typically an access issue for our clients historically. I will just say, you know, just to answer one of the other questions about stressors and DHS mothers compared to the rest of LA County, you know, I will say that we, when looking at different, you know, when stratifying and looking at different portions of our cohort, you know, we have rates of anxiety and depression, for example, in African American moms that are much higher than national averages and much higher than LA County averages as well. So the screen positive rate for anxiety and depression is closer to 45% in that population. You know, nationwide, it's certainly not that high. And even in LA County, in a more mixed ethnic cohort, generally speaking, you know, the sort of the higher end of that rate is about half, is only about, you know, 20% or so. In our Latinx or Latina moms, we see screen positive rates for depression and anxiety closer to like 30–35%. That's just one example. You know, our housing instability or homelessness rates are higher than national averages. We have something like 30% or 35% of new intakes every month have screen positive for some version of housing instability that might not be frank homelessness, but might be couch surfing or living in a car or something like that. So yeah, we certainly see social stressors out of proportion within DHS, even to LA County, and sort of LA County, you know, versus some of the national averages are, you know, they're more consistent with those rates of preterm and low birth weight. So that is one of the reasons that we're seeking to do this cross-sector approach to mitigating some of those risks. I'll take one other question just while I'm on the topic of this social support or stress of fathers, significant others, et cetera. We haven't measured that systematically for all comers historically. We do involve partners in our prenatal and resiliency classes. And so for those folks, we have had PHQs, GAD-7s, and global self-efficacy scores at the beginning, middle, and end of our 8-session classes. That's the combination of prenatal and resiliency, or sort of CBT light, that I mentioned earlier. So that's the only sort of cohort in which we have an assessment of fathers and partners. We will be expanding some of our fatherhood work and partner work, you know, in the coming, you know, next 5 years or so, and, you know, we'll be doing some more systematic assessments. But, you know, in some of our at some of our sites, we have, you know, up to a 50% lack of partner involvement in general, or, you know, single parenting, single pregnant and parenting women. So, you know, it does present some challenges in terms of assessing partnership systematically, as those folks can be somewhat engaged and disengaged variably throughout the course of the pregnancy and the first year of life.
Thank you, Erin. We have time for about 2 more questions, and then the next question is, after the study is complete, what are some barriers you anticipate in implementing this program, particularly with healthcare delivery organizations? How can healthcare provider and payer organizations implement the data from this study to better sustain long-term care and delivery? And I can repeat both questions if you need me to.
Erin?
Yeah, so we started implementing this program in late 2014, early 2015. So, you know, we have a lot of barriers known, not anticipated. You know, certainly just the sort of legwork that's required in actually activating the network and coming up with affiliation agreements or MOUs between partners to really do the cross-sectoral kind of engagement it's a lot of investment of time. It's a lot of relationship building and sharing, and we've done a lot of, you know, neighborhood engagement activities to try to bridge those gaps. LA County DHS, for those of you who don't live here, hasn't necessarily been the best neighborhood partner in decades past, and so there was a lot of there was and still is a lot of you know, historic kind of challenges to overcome. And so I think some of that just speaks to, like, this is a long haul kind of a program. It's not something that you can stand up and then, you know, see if it works. And, you know, it really takes incremental improvement and deepening of those relationships over time. Healthcare providers and payers are very interested in what we're doing here, because really the return on investment, I mean, you can spend quite a lot of money up front to prevent a preterm birth, because preterm births are, you know, billions of dollars to payers every year. And so, you know, it's certainly, the return on investment is quite good if you can make an impact. But that said, you know, it really does take a sort of a capitated model or some sort of value-based payment, because there are a lot of non-direct services being provided, both in the setup and the maintenance of this, you know, these neighborhood relationships and the IT systems to link people, as well as, you know, the non-clinical or paraprofessional type of service provider that we utilize in a community health worker, for example, to do the work. And so, you know, it does take some sort of capitated structure or, you know, other bundled payments so that you have the freedom within a health system to, you know, to use those dollars to support a more team-based and collaborative approach. But the ROI is pretty good when you're, again, looking at an outcome that's this costly.
Great, thank you. And then the last question that we'll have time for today is, how did you initiate or receive buy-in from the contracted agencies to create the neighborhood networks, and how difficult was that?
So we did a lot of convenings. You know, we worked with some trusted partners who had been, I will just be frank, better actors in the community over, you know, the last couple of decades than DHS had been as a partner. And so, you know, DHS was undergoing a big transformation and a new sort of leadership change at the time, big picture, not just within women's. And so, you know, I think it helped to kind of have a reset, reframe going on countywide, and that was fairly, you know, publicly known. But we worked with our county council and trying to create some agency agreements that weren't too cumbersome for what oftentimes are, community-based organizations or NGOs that don't have big operating budgets and don't have their own, counsel that they want to pay to review agreements. And so trying to come up with, we have a tiered system of sort of relationship sharing. So how much information do we share from clients at their request with you as an agency? How much are you willing to receive? And really trying to streamline that and make it more uniform, so we're not creating a different kind of relationship with every neighborhood entity that we're working with. And so, we assumed that work on our side with our council, and then we're able to sort of put out a blueprint, a sort of an option A, B, or C for neighborhood agencies. More importantly to them, we, in our neighborhood convenings, really sought to find a win. So, what were the barriers that they had to getting clients to, high quality OB care? What did they need from us as DHS to complete what they saw as the complete picture of needs for their clients that they might be seeing in substance use treatment, or that they might be working with at a women's shelter, or et cetera. And so some of that we overcame by creating encrypted referral entry portals. So we can get referrals pretty easily from other healthcare providers, other doctors, but we couldn't get referrals very easily from our neighborhood partners. So making an online encrypted form that they could log into and submit, creating an encrypted email account that they could send questions and queries to, and creating a dedicated 800 number where they could also, call and either get somebody live or leave a message that we could, return within 24 hours to connect people to care more real time from us to them. And so it wasn't just us sort of sending folks out into their services, but also for the folks that they encountered, having a more real-time way to connect them to services and to care was a huge part of that relationship building. So, finding the win was critical.
Great. Thank you. So that's all we have time for questions today. And I just want to take some more time to thank you all for joining today to share a little bit about your research. I know you're in the early phases, but we're really excited about what's going to unfold over these next 2 years and see what findings you have. So thank you so much for sharing that with us today. Let's see, other announcements. We do have another Research in Progress webinar on December 4th from one of our groups that is wrapping up their research project this month. So they should have some exciting findings for us. And then our next webinar will take place after the new year. So it'll be in January, and that is to be determined who is going to be presenting then, but we will send out emails and announce that in advance. And so with that, we have reached the end of our webinar today. Thank you so much for joining, and hope you have a great rest of the day.
Thank you, Karen.
Thank you.